Kessel, Director of WHO Mental Health and Substance Use Department. She will join us shortly. And an excellent lineup of distinguished speakers from the civil society, countries, and partners. This webinar is important to place a special spotlight on the linkages between TB and mental health disorders. TB, its treatment, and the stigma attached to the disease are a major cause of suffering for people affected and their families. The prevalence of mental disorders, including depression and anxiety disorders among people with TB, is estimated to be between 40 and 70%. And there are several important factors at play. First, patients with mental disorders are at increased risk exposure of TB infection with higher rates of homelessness and residence in shelters and group homes. Patients with mental disorders also carry other risk factors for TB, including smoking, poor nutrition, and comorbidities such as diabetes and HIV. In addition, people living with TB and mental disorders are less likely to seek health care and may be less able to adhere to treatment, with consequent adverse treatment outcomes, including morbidity, mortality, drug resistance, and ongoing treatment transmission. Furthermore, several anti-TB medications may precipitate more severe forms of mental disorders, including major depression, anxiety, or psychosis. There is also evidence of increased risk of suicide behavior among people living with TB, including among women, those who are being retreated for TB using alcohol with the previous psychological distress or post-traumatic stress disorders. The COVID-19 pandemic has further exacerbated the situation for people with TB and those affected by mental health disorders. To address this, we need both national TB programs and programs addressing mental health issues in countries to collaborate closely. We welcome you today to this webinar and invite you to submit questions using the online chat function. Our panelists and team will respond online, and certain questions will be curated and answered live, of course, depending on the availability of time. So with this, I would like to start and would like to invite our first distinguished speaker. Zoleba Sifumba is a medical doctor currently doing her community services in rural South Africa. After having contracted tuberculosis as a result of her occupational exposure during her studies, struggling through the treatment process and finally beating it, she has been a strong voice in the global fight against tuberculosis. She will share the challenges she faced while taking MDR-TB treatment and struggling with mental health challenges. Please, Zolea, floor is yours. Share your experience with us.
Hello, everybody, coming from the beautiful South Africa. Hi, thank you so much for having me today. As she said, my name is Dr. Zolelwa Sifumba, and I am a medical doctor practicing in South Africa. So I'll just jump into it. I am an occupational multi-drug resistant tuberculosis survivor, and I'm basically, here to share my story. So basically, a couple of years ago, as a medical student, I woke up with a lump on my neck, and I had no idea what it was. But it was growing and it was more painful, and I definitely had been exposed to tuberculosis in the wards that we work in. But because of a lot of the stigma that is around TB, I was very much in denial of the fact that I was, possibly having TB. And even when the diagnosis came, even when I got my results back, after doing a lymph node biopsy on the lymph node, the results had come back saying that I had multi-drug resistant TB, basically. So basically what I'm here to talk about is the struggles that I went through, because having multi-drug resistant TB was probably the hardest thing that I've ever had to do in my life. The treatment itself was extremely difficult. When I was on treatment, I was very isolated from the people around me. And I think the biggest problem was the actual side effects of treatment. So I was taking, at the time, 21 different pills, as well as an injection, which could have taken away my hearing at the time as well. And those pills left me every single day nauseous, vomiting, with diarrhea. I was completely debilitated, to the point where I actually had to leave medical school because it was just so difficult to juggle the side effects of treatment with actual everyday life. So every single day of that treatment, I really felt like I was eating poison, because of how toxic the drugs were, how terrible they made me feel. And even though I knew I had to take these drugs for about 18 to 24 months at the time, which made the suffering even worse, So I was depressed at the time. And I was experiencing suicidal thoughts. I had told myself that basically if TB didn't kill me and the medication itself didn't kill me, because I also went and researched all the side effects of the drugs. So I realized, if the TB didn't kill me, then the medication would kill me. And if the medication didn't kill me, then I would kill myself, because it was suffering, and every single day of that treatment, there wasn't a single day that went past that I didn't want to default treatment, not because I didn't know better. I mean, I was a medical student and I knew about TB. I knew how, obviously if I took the treatment for MDR and I defaulted on the treatment, then I could find myself with XDR, and that was also a very scary thought, So every single day I wanted to quit. I was scared to continue with treatment, but I was also scared to stop treatment. But I was told, look, this is what you need to take and this is what you have to do, in order to treat this disease, and basically my experience is the reality of millions of people globally. Multi-drug resistant, whenever I meet someone that's on treatment for drug resistant TB or someone that's been on treatment before, it's like we already know, how much we went through or how much we're going through. And this is why I actually like to support people that are going through drug resistant TB treatment, because even though it's years later and the injection has been removed and, we've got bedaquiline and we've got linezolid, but the treatment still feels like poison, it still feels like poison. And I don't understand what it is about the pharmaceutical companies that don't see the use in making the treatment less toxic, because you have to go through it every single day, But anyway, I think the lack of the holistic support in treating patients that have TB has helped TB continue to kill millions every year, because it's not enough to just be on the treatment, it's not enough to just be on the drugs, because we're not bodies, we're not just lungs. As people, we are social beings, and everything that affects our bodies will in turn affect the way that we interact with the rest of the world. And when I had TB, I was just sick all the time. And even though I took my medication at night, during the day, a lot of those side effects would come back. And the worst part of treatment was the injection, which I'm so glad there was a push, to get away from that, because that injection was so painful that literally 2 days after you've started the injectables, the pain is shooting down your legs, it's shooting up your back. And now it's difficult to sit, it's difficult to stand. And I had to go, I had to continue with medical school, because obviously living in South Africa or living in any sort of low income country, that you just have to push and you have to work so that you can get a job. So I basically told myself that I had to continue, even though I was in so much pain from the daily injections, even though I was constantly nauseous. And I mean, people have taken, I mean, you've all had an experience of antibiotics. Usually people after 3 days of antibiotics, they're just like, yeah, I'm okay. So now we were expected, to take drugs for 18 to 24 months, which I think was quite cruel, and even when I'm prescribing medication to my patients, I'm just like, oh my gosh, like I know exactly what the thing is going to do to you. And I'm really sorry, but what I've decided, for myself, for the patients that I treat that have TB, I realize that the support that they need to actually complete that treatment process is a lot more than the drugs that they're going to need. So I make sure that I counsel people to actually understand. That's another thing. There was zero counseling of what side effects I should expect. And I really felt as though that was really unfair, But basically, my message is that we need more than drugs. Yes, the drugs are the thing that are going to help to defeat the bacteria eventually, but we really need to understand that these are people that we're treating. So yeah, anyway, I am so happy to be speaking here and to be a part of this push, because I definitely think this push to integrate these services and to understand the mental health and well-being of people that have TB is really going to improve the survival of people. I think this has been one of the reasons many people have still been dying. And I mean, people ask the question, why? We've got drugs, we've got, what aren't we doing wrong? The thing that we aren't doing right, sorry, is that we're not supporting people through the treatment. So my question is, what's the point of putting people on treatment if you're not going to help them through the actual treatment? Anyway, we need more support. We need more support. We need more support from the WHO, from donors all over the globe, because this is how we end TB. This is how we end it. And just a reminder for everybody, TB is not just a problem for, the poor. TB is not just a problem for people of lower socioeconomic standing, it is a disease that can affect every single one of us because we breathe. And I like to remind everybody that just like, COVID has come and shown us that there is an infectious disease that can pass from person to person, that can kill people via the breath that we take every day, So I'm basically, my message is that we're all at risk of contracting TB. And that's why I feel like this is a very important thing for us to be doing. This is a very important push for us to be making against the illness, because so many people are struggling through treatment. And it's not enough to just have them on treatment. It is not enough to just have them on treatment. So I want to just encourage all of us that are here today. I think we can all be advocates for this. We can all be advocates for the better treatment of people that have TB. Because as I said, it's not enough to put people, I thought I was going to die. I was sure that I was going to die, in fact, because at the time, the stats were saying that only 40% of people on treatment actually made it through, So the whole time, and I definitely, it contributed towards the depression, the toxic drugs, the large number of pills that had to be taken, the long amount of time that the drugs had to be taken for, it all seems impossible. And the only reason I'm here today is because I was assisted by other TB survivors. So in closing, I want to say the voices of us as the voices of TB survivors aren't listened to enough. And I think as a part of this great movement that we are a part of, and you are pushing as WHO, I really think it is important to hear us out as the survivor community, because like I could have told everybody all of this like years ago, that okay, people are dying because treatment is hard. I mean, So anyway, thank you very much for having me. another reminder, it is all of our problem. As long as we all breathe, it is all of our problem, and we are all at risk of contracting TB. So we really need to do something about it. Thank you.
Thank you very much. Thank you very much, Zolea, for your very strong messages and sharing your really dramatic history, which clearly highlighted all the problems patients with TB are suffering. And of course, we are trying all together to do our best to advocate for the access for all TB patients, for the better treatment. And as you've mentioned, luckily we managed to update our guidelines and propose much better and safer treatment options for the patients with the drug-resistant TB. We are strongly recommending fully oral treatment. It is now much shorter, and in these current circumstances, in the COVID pandemic situation, it's becoming the only one option to provide home-based treatment with the drug supplies, but in the same time, people affected should not be alone. Someone should be next to them and to support to overcome all these hardships. They are not only related to the disease itself, but also, unfortunately, to the treatment. And we should continue advocate together with you to the manufacturers and invest more in TB research, because how it could be possible, I'm highlighting in the 21st century, we are the treatment of TB is still so long with such a toxic drugs. So that's why thank you very much. Please stay close to us. We will be happy also to support, to be engaged. Only jointly we can really make difference for other people suffering. Thank you. It was really very inspiring. And with this, I would like to move from my colleague from South Africa to other colleague working here in the Global TB program now with me, Dr. Ernesto Jaramillo. From Global Tuberculosis Program, and I would request him to share our vision and policy perspective on the management of TB and its comorbidities within the WHO and TB strategy. Indeed, our request for the patient-centered approach is becoming even stronger because we should not put our patients under the risk. We should be closer to them. We should be able to monitor, to support in the different situations related to TB, to the mental health and other comorbidities. So Ernesto, I'm giving floor to you. Please share your thoughts and our policy vision.
Thank you very much, Teresa. I'm going to be brief. I just want to give one key message, is that comorbidities are key drivers of the epidemic. And within the NTB strategy, we have the pillar one called integrated patient-centered care. And within that pillar, we have mental health. Next slide is going to show you how in a global TB report of last year, for example, we are making very explicit how key drivers like smoking, diabetes, HIV, harmful use of alcohol, malnourishment are contributing to the number of cases that are occurring every single year. Hence, it's not enough to take care of tuberculosis, because the people who suffer of tuberculosis also have many other health conditions, and we must take care of that. This is one of the fundamental components of the patient-centered approach. Next slides are going to show you, for example, right, how within our pillar we have 4 components, and collaboration with the programs that are taking care of those comorbidities is part of the response. When we talk about patient-centered care, sometimes this sounds like a bit philosophical concept, but actually it's extremely practical. A patient-centered approach means that the needs, the values, the perspectives of the person affected by tuberculosis must be taken into account. When someone comes with a diagnosis of tuberculosis, it's not enough just to focus on the tuberculosis disease. That person has some responsibilities with the family, has some expectations, has some preferences for the decision they are making in their life, but also they are living in a society. Hence, when we respond to the needs of the patients, when we need to take into account their values, one of the components of that response includes the other diseases they are suffering of. Mental health is emerging as a major comorbidity, as a fundamental issue that we need to address. Next speakers are going to show you the evidence that is piling up in the recent years. But in the meantime, let me tell you in the next slide how in the NTB strategy, we are providing some guidance about how national TB programs, healthcare providers can contribute to address these comorbidities. But the next component of the NTB strategy, pillar 2, next slide, shows you that it's not enough to address the health services dimension. We need to have a multi-sectorial approach. And within this, we need to see how addressing mental health, for example, has to be embedded within the more comprehensive social protection network, within the approaches for poverty alleviation, and above all, for ensuring universal health coverage. This is fundamental in order to address all these major comorbidities. Finally, my last point is in the next slide, which is that we are facing a challenge in which there is an awful dearth of evidence. We do not have yet all the evidence we would like to have to move forward in implementing an agenda for mental health. However, what we have at the moment is sufficient to at least address the basic needs and to plan the most simple elements of a collaboration between the two programs, which is basically to make early detection of the comorbidities and implement the recommended action for addressing this. We also need then to, in parallel, pursue further a research agenda that can help us to improve our understanding of how the intersection between these two mental health problems and tuberculosis are contributing to shape up the direction and the size of the epidemic. I hope that within this webinar, our next speakers are going to share what is the state of the art at the moment and how can we together mobilize to really end tuberculosis within our time. Thank you very much.
So thank you very much, Ernesto, for your very important highlights, for reminding key pillars and principles of the NTB strategy. And of course, you've mentioned also about the evidence. Evidence is becoming critical for us as WHO to develop strong policies and guidelines and to the programs, to the countries. And of course, we expect that we will be again together. We'll advocate to the researchers, to the manufacturers, to the decision makers, senior officials, request to invest more in the research and provide evidence, share with the WHO evidence for development better policies. So with this, I would like to move to another speaker, Dr. Aisha Malik, my colleague from the Department of the Mental Health and Substance Use. And Aisha Malik is a technical officer with a very rich experience as a clinical psychologist in integrated care, in infectious disease and immunity, especially in HIV and sexual health. Aisha will present the current evidence on the relationship between mental health, substance use, and TB epidemiology, and the potential for rationale for integrated care. Please, Aisha, floor is yours.
Thank you so much. I hope you can see my screen.
Yes, we can.
Perfect.
Yes.
So I'll just run through, first of all, what we know about the evidence. And I can see we've got a couple of questions about that at the moment. And then I hope to go a little bit more into what action we might be able to take. So if we consider the question of whether comorbidity between mental health and TB is common, I think we can say we are quite confident that this is indeed the case. And this is really starting to build a picture towards moving towards integrated and person-centered care. Now, obviously, you'll see the spread of those figures is wide. And although traditionally one might leave this a little later in a presentation to say, it's worth saying that the research that we do have is of mixed quality. I think it's important to flag this because ultimately this calls for a substantial improvement to the research, which will only add to our efforts in this area. I think ultimately this also says that it's very likely that many people working in the TB field have encountered somebody living with a mental health condition, and quite potentially vice versa for those working in the mental health field as well. The same can be said of multi-drug resistant TB. So this is a review that you may be familiar with, conducted 40 studies across 20 countries. And the most common conditions are depression and anxiety disorders, which by virtue are common mental health conditions, and also psychosis. I think this particular review flagged some important points, extending beyond the biomedical view on health, which is there were common social stresses involved: stigma, discrimination, lack of social support, and much poorer quality of life in people living with multi-drug resistant TB. And all of this starts to point us towards the need for integrating mental health care, as well as social protection, as well as social support measures in the care of people living with TB. So the same can be said of people living with alcohol-related problems as well. So in this meta-analysis, alcohol-related problems are associated with almost 3 times the risk of tuberculosis. And alcohol consumption in this particular study was thought to contribute to about 22% of the incident cases. I just want to double check that I haven't skipped over a slide because I was expecting another slide there. No, apparently not. In case it doesn't, yes, in case it doesn't come up, I did have a slide talking about, we've got an issue of mental health being prevalent in populations living with TB, but also TB being prevalent in populations living with mental health conditions as well. And the evidence for that isn't synthesized evidence at the moment. It's actually population studies that have taken place in large population studies, usually retrospective longitudinal design. And I'm aware of 2 papers, one for schizophrenia and one for depression, both showing that there is an increased likelihood of TB in both those groups compared to patient populations without those diagnoses. And it's also worth flagging here that TB meningitis is possibly prevalent in almost 500,000 people each year worldwide. So I've seen a couple of comments actually on querying this bidirectional relationship. It's a tricky concept, but I'll try my best to cover it here. Indeed, people with tuberculosis are at increased risk for mental health conditions. And it looks likely that people living with mental health conditions are often at greater risk of TB. And I think I've seen some questions around the extent of the evidence around this. And I'd like to alleviate or reassure the audience that mental health is complex by nature, with many multiple different pathways that can contribute to it: biological, social, psychological, environmental. And then when we think about it in conjunction with chronic disease, it can be a lot to conceptualize, but it makes sense in context. So here we have a circumstance of 2 health conditions with shared social determinants. For example, poverty, although we heard from our earlier speaker, not alone for poverty, but poverty certainly in relation to alcohol use disorders. There are shared stressors between TB and mental health, no less stigma, discrimination. TB in itself, receiving the diagnosis, initiating treatment, is an adversity. And adversity is one of the most common, well-established risk factors for mental health. We also know that people living with mental health conditions might present with health risk behaviors, might be in environments that lead them to greater exposure, might, as the very nature of their clinical presentation, be put in situations or make decisions that might leave them more vulnerable. All of this points towards increased exposure to TB, and vice versa for TB to mental health. As I said, TB in itself is an adversity, and there might be a reaction at a psychological level on diagnosis. But I think what we need to understand a little bit more about is the trajectory. It's not uncommon to experience distress after diagnosis, and we'd expect this to decline naturally in most cases, but we do need to understand more about that. So this, sorry, apologies, there seems to be an error with this slide here. Ultimately, we need to think about, whilst we think about the complexities of these multiple pathways, it's a lot to think about, but that's one aspect of it. Ultimately, we also want to think about how does mental health and substance use comorbidity impact TB outcomes. We know it's associated with treatment delay or diagnostic delay, resulting from a complexity of factors, no less potentially reduced help seeking, which we know is common, and less likely to seek testing for TB. It might contribute to drug resistance, in part due to difficulties with adherence, and it might contribute to defaulting from treatment, which is common, particularly with mental health difficulties and substance use, and mortality as well, but I'll say more in just a moment. So this is a pre-release of a paper conducted by some of our colleagues here in this forum, which tries to tell us a little bit more about the extent of the impact of mental health on TB outcomes. So this is really important. If we can understand better around outcomes, there's an indication that targeting mental health might be something that helps improve TB outcomes. So here what we're seeing is that there's almost double the risk of any poor outcome as a result of mental disorders, so any poor outcome related to TB, and potentially around double the risk for loss to follow-up, and also some risk in terms of non-adherence. Although in this particular paper, they actually did report a common issue, like I cited at the beginning, where difficulties in statistical heterogeneity, but also the way or the different ways in which adherence is measured sort of contribute to impacting the effects that were calculated there. And although not subject to meta-analysis itself, and I think this is really striking, particularly from speaking as a mental health professional, that depression was associated with near to 3 times the risk of mortality, which is quite shocking from our perspective. So what can we do to address comorbidity? It's a common theme of integration and person-centered approaches. I'd like to tell you a little bit about the tools that we've been developing here in the WHO Department of Mental Health and Substance Use. So one of our program areas is called the Mental Health Gap Action Program. This has been developed in response to a lack of specialist workforce for mental health in many countries, particularly low and middle income countries, and the treatment gap that exists. So in line with our objectives in our comprehensive mental health action plan, this speaks to integration of mental health in primary care. So this includes building capacity of primary care providers or other practitioners to assess, manage, and intervene for mental health and substance use conditions and neurological conditions. It includes operational guidance for integration of care by district health managers. It includes manualized psychological interventions, which can be delivered by lay providers. And we know that there's good evidence for task shifting and for collaborative care models in mental health. And I think we see a lot of potential promise for this application in other health conditions or other chronic diseases as well. In addition to those, I just want to also flag to you the numerous tools that we also have for alcohol and drug use disorders as well. I'm actually going back to this just to make the point to say we've implemented MH-GAP across many countries around the world. So I saw a comment on that, on where has this been implemented. What's also very important to point out, particularly as I was talking about potential risk in institutions, is we also have guidance and training around human rights-based and recovery. These are essential in mental health, where the treatment of people with mental health conditions is subject to a lot of human rights violations, and in itself forms an essence of person-centered approaches. And again, here we're working toward, we've done much work towards this, but we're also working towards integrating depression care and chronic disease care through the development of a model module. So one of the things we understand about mental health, even in its complexity, is that the interventions for it and the care pathways for it are not that dissimilar in terms of the components of treatment, or the format of those care pathways are not that dissimilar between population groups, whether it's adult, whether it's child, whether it's someone living with HIV. And we would anticipate potentially something similar when it comes to tuberculosis. So we see good promise for extending the lessons learned in mental health and the work that we've done in some of these countries in terms of integrated care. And finally, just to add a few reflections here on what might be needed going forward. And I've mentioned some of these already. So we'd need rights-based policies if we were thinking about integrating care. There needs to be a lot of awareness raising and advocacy, particularly when it comes to the dual stigma that's experienced. Ultimately, any integration of care still does require access to specialist mental health services as well. Task shifting is very promising. There's a great potential to train both people working in TV or primary care in terms of mental health identification and management. Essential to have access to the essential medicines and also psychological interventions, and ultimately multi-sectoral collaboration is necessary. I'll stop there. Thank you very much.
Thank you very much, Aisha. Very impressive and very useful information. And you are right. It's obvious that the linkages between mental health and substance use and TB are obvious, are clear, and we should address definitely these issues. And especially when we are looking at the evidence data, it's striking. It's striking. We can't ignore it anymore. And when we are talking, if we are serious about ending TB and providing progress, we should definitely take it into consideration. And I think that all the tools and information on training modules which are available will be very helpful for the practitioners, and we will continue informing them, and we'll stay in touch. And I think that it is actually the first in the newest history of a webinar like this, but we will continue definitely. And we'll be happy to receive your reflections, your comments, and I can see already now we're receiving a lot of very concrete questions, and I hope that we will have time to address them. Thank you very much, Aisha. And now I would like to move to another speaker, and actually I like very much the title of his presentation, Mental Health Needs of People Affected with TB, Let the Mind Breathe as Well. And the speaker will be James Sale from UK, representing United for Global Mental Health. So he is the policy advocacy and financing manager, and who campaign and advocate for greater legislation and financing for mental health. James has spent the last 10 years advocating for equity in health system, particularly through increased health financing and better governance. He will explore what those living with TB require from health systems and leadership to ensure they have the highest attainable level of mental health. Extremely important topic again, and I would request to share with us your ideas and information. James?
Thank you very much, and thank you for inviting me to this really important and excellent event today. Originally, I was asked to talk about the mental health needs of people affected with TB, but I want to take that question slightly broader and look at what is needed to have the most positive impact of the mental health needs of people affected by TB. And there's many, many things that are important to make that happen. And I'm going to highlight 4 today. So the 4 areas I'd like to talk to you about are that those affected by TB need their individual mental health needs understood, that those affected by TB need their mental health rights upheld, that those affected need global and national leadership, and that those affected by TB need their voices to be heard by policymakers in a meaningful way. So to take that first point, that the individual needs have to be understood, improving quality and ensuring people-centered care, as we've heard already today, requires addressing the economic and psychological stress experienced by those affected by TB. This stress results from issues such as TB stigma and social isolation, discrimination, transport costs, and lost income. Now, these factors can make TB treatment completion really difficult, as we've heard from several speakers today. And so as such, they represent access barriers. Now, to overcome these, there are a range of measures that are required, that they need to be part of a holistic approach that is hardwired into health and wider government systems through policies such as universal health coverage. But at the core of that, the individual needs are heard and responded to. And this is crucial because currently those living in mental health conditions disproportionately suffer. I've always struck the fact that those with severe mental health disorders, not just those living with TB, die 10 to 20 years earlier than the general population. There is a huge inequality about how we care for those with mental health conditions. And this is compounded by the additional physical health conditions that, such as TB, can present as well. Now, the core of this, and arguably the greatest need for anybody affected by TB, is the need for their rights to be upheld. Mental health is a global public good and a fundamental human right for all. Mental health policies and laws and interventions for treatment, prevention, and promotion should be compliant with international and regional human rights instruments and frameworks. These include the Convention on the Rights of Persons with Disability, which promotes, protects, and ensures the rights and fundamental freedoms of all people with disabilities, including those with mental health conditions. And so by not fully integrating mental health into a patient's treatment, we are denying their full right to health, the highest attainable level of physical and mental health. In particular, we need to promote and protect the rights to good mental health in key populations that are vulnerable to ill mental health and TB. In focusing psychosocial support efforts on these vulnerable populations as part of a holistic TB approach, health systems will also be fighting inequities. The most effective way to uphold these rights is to integrate mental health into universal health coverage. And so by placing mental health at the heart of the approach, primarily through primary and community level care, health systems can lay the foundation for universal mental health coverage. One of the biggest challenges to achieving universal health coverage by 2030, in my opinion, is it being incomplete in many health systems, as mental health will be left out of service packages. And as Dr. Tedros says, there's no health without mental health. So integration of a holistic approach to TB that has mental health at its core is actually not enough. This approach has to be embedded within universal health coverage reforms and progress. So allowing those affected by TB to benefit from the wide range of services that a good functioning health system can provide, and not allowing TB programs with good mental health services at its core to be vertical or siloed. Now, this depends a huge amount on having adequate finance. To fund mental health integration into TB programs should ultimately not rely on specialist or standalone budget lines, but rather draw upon an adequately financed mental health system within the wider health system. To achieve this, governments need to allocate and spend 5 to 10% of their health budget on mental health, as the global recommendations say. Now, this brings greater efficiency gains to health systems. And economic modeling suggests that for every $1 invested in treating mental disorders, up to $5 can be saved in economic cost and health returns. Now, that stat is known by, I think, everybody who works in global mental health. But maybe what isn't so well known is that for TB, the savings are estimated at $43. And this is a financial benefit to governments that is just so clear it cannot be ignored. This type of finance not only gives a return on investment, but also allows for a return on the individual. By investing in mental health systems and the mental health of those affected by TB, the returns go beyond just dollars and cents. We allow people to realize their potential at work, within their communities and within their family units. And crucially, universal mental health coverage allows for those with TB to access the care they need and not have to make decisions about which part of their treatment they can afford or which part of their life will have to suffer due to lack of finance. Not having the means to access treatment not only adds to stress and anxiety, ultimately it prevents people from accessing the treatment they need for their mental health. WHO's comprehensive mental health action plan, which has already been highlighted today, is the key framework for integration of mental health, and needs not only to be supported by governments at global moments, but also when they arrive home through adequately financed implementation. Now, the third area I wanted to talk about was that those affected by TB need their voices to be heard. And therefore, we need civil society organizations to be engaged with policymakers in a meaningful way. Space is needed for those living with lived experience of TB to engage with policymakers. Nothing for us without us. It is critical that decision makers not only consult with those with lived experience, but actively engage them in the decision-making process. Those in positions of power can actively seek and engage with local TB and mental health civil society groups and service delivery organizations who understand the subject of ill mental health and TB within communities and within vulnerable population groups. These organizations will be able to provide much needed expertise on how to tackle the challenges of ill mental health in relation to TB within the local populations and have a significant impact on local TB outcomes. This is particularly crucial for several key populations, such as gay and other men who have sex with men, sex workers, people who inject drugs, and other vulnerable groups, homeless or those who are incarcerated, to tend to have higher levels of poor mental health and substance abuse, in part due to stigma and discrimination relating to their identity. Key population groups and vulnerable groups of TB have many similarities with people who are more susceptible to poor mental health, which we heard in the last presentation. Now, finally, I want to just talk about the need of those affected by TB to have good and strong global and national leadership. Of all these needs given above that I've spoken about, all of this is within the hands of national and global leaders. Ultimately, it is national and subnational leaders that can have the biggest impact on mental health of those living with TB. To achieve this, national leaders need to think about the individual, as I've already mentioned, their needs, but also their potential. And some governments will require outside guidance and support. And that is why institutions like the Global Fund and their relationship with national leadership is so important. The Global Fund has the influence to be able to shift the approach to TB and mental health treatment. It already finances mental health support through psychosocial support in many countries, but they can do much more to work with those countries, specifically with mental health and TB. For example, the current Global Fund strategy could go further in recognizing the cross-cutting co-epidemic of mental health and substance use disorders. so that if treatment of these disorders was closely integrated with efforts to end TB, the prevention and care outcomes would be strengthened and access to mental health would be improved, mental health care would be improved. Especially in settings where political will already exists, there's an opportunity for the Global Fund to fill the critical capacity and resource gap that would make integration possible. And an excellent way to achieve this would also be for the Global Fund to more closely align with the WHO Stop TB strategy. A hugely progressive step would be the full integration of mental health into the next Global Fund 5-year strategy, which is being discussed at the moment. And this does have a lot of support from key stakeholders in that discussion, but this still needs to be realised. And I do hope that mental health is a key discussion point during the November board meeting of the Global Fund. And with this support coming from institutions at the global level, such as WHO and such as the Global Fund, countries therefore have the ability to be able to integrate mental health support into TB programming. And given the evidence base which we've already discussed and the support that's out there, there really is a great opportunity for countries to have huge progress in this area. Because as much at the individual level, there's a need for a coordinated, integrated, and progressive approach to mental health and TB. So too is a coordinated and integrated progressive approach required for those in power. Thank you very much.
So thank you very much, James. I can't agree more with all your points. And of course, we can advocate all together, but without financing, it will be extremely difficult to implement all our excellent ideas, guidance, and proposals. We should be very focused on the patients and on their needs. And as the person responsible for TB care, of course, I cannot be happy if I will treat a patient with TB, but at the end he will fall ill with as a result of TB treatment with the chronic mental disorder. It's not the desirable result at all. So that's why we should definitely try to change our traditional mindset and find other solution. With this, I would like to stop and to give with pleasure floor to my colleague, whom I introduced at the beginning of our webinar, Deborah Kessel, Director of the WHO Mental Health and Substance Use Department. She just joined us, and she will continue this very impressive, important discussion.
Thank you, Teresa, and sorry, colleagues, for being late here and those connected. I did already other 2 presentations in the last couple of hours because of this is our week. I guess mental health is a priority. Thank you very much for this opportunity. And I see that I arrived, apart from listening to the comments from James, I arrived right in time to a question that is of high interest to us. Are the national TB program managers ready to embrace collaboration with mental health services? That's $1 million question that I'm very curious to listen to the answer to. And so we will hear the evidence from a global survey. So I'm inviting Annika Switzerland, assistant professor of University of Columbia in the US, to tell us a bit about that. Annika is an assistant professor of psychiatry and public health at Columbia University, and her research has focused on the intersection between TB and mental health since the late 1990s. She co-founded the TB and mental health working group of the Union and leads advocacy efforts in that area. She will then present the results of a survey exploring the awareness of NTP managers on mental health issues in TB and their willingness to develop collaborative models of services. So, Annika, floor is yours, and we are very interested to learn about these results.
Thank you so much. Can you hear me?
Yes.
Wonderful. So thank you very much for the opportunity to be here today. I look forward to today sharing the results of a survey that we conducted a few years ago on behalf of the TB and Mental Health Working Group at the International Union Against TB and Lung Disease. There were a few questions that we sought to answer with this study and speaking to TB program managers globally. The first was, what are the main perceived barriers to TB treatment success? And in particular, we were curious if, in asking this in an open way, if mental health and substance use disorders came up spontaneously as one of the perceived barriers. Second, we wanted to understand what the current practices and protocols were for addressing TB and mental health comorbidities at the national level. We wanted to understand what the receptivity, again at the national level, would be to integrating TB and mental health. And finally, what the top perceived barriers would be to integrating TB and mental health services if they were not already. The design of the study was a cross-sectional, semi-structured survey. The target sample were national TB program directors from high burden countries, although we didn't restrict to that. The data collection was in the form of a 22-item questionnaire, mostly multiple choice. We were very flexible about the way in which we collect the data, just in terms of trying to increase the representation. And so we initially started recruiting in person at the annual union conferences, lung conferences. But then we also made the opportunity, we did it by Skype or phone or in writing, however we could get these responses. The data was collected between October 2015 and June 2017. And the final sample included 26 countries, 80% of which were high burden countries. Some of them were considered high burden for more than one category of TB and HIV co-infection and drug-resistant TB. And when we asked in an open way, what are the main perceived barriers to TB treatment success? These were the main reasons that were cited. Lack of knowledge, distance or transportation issues, side effects from the medications, poverty-related factors, system failures, substance abuse, stigma. And interestingly, mental illness did not come up spontaneously. And the reason why I highlight this is that we've learned more and more in recent years, and as has been highlighted in today's presentation, that people with TB, the proportion of people who struggle with mental disorders and substance use is relatively high, and it tends to be under-recognized. And mental disorders are a treatable condition, and this is a very actionable way that we can, using patient-centered care, improve outcomes for TB. The second question was what the current practices and protocols were at the national level in these countries. Very few were conducting at that time routine screening for common mental disorders, including depression, anxiety, psychosis, and/or trauma, only 8%. And slightly more were conducting routine screening for alcohol and drug use, but only 15%. In terms of current practices and protocols and services that were available, just over half recognized peer support groups as being available for as a psychological support. Although one thing that I'll note here is that most of the respondents gave the caveat that it was tended to be for multi-drug resistant TB patients and not always for drug susceptible TB. Some form of mental health counseling in nearly 20%, and psychiatric referrals in 23%. Next, we wanted to know what the receptivity was to integrating TB in mental health services. We know, as we've discussed today, Dr. Malik described the mental health action program at the WHO. We've identified through the last couple decades a number of cost-effective, brief, effective interventions that can be delivered by non-specialists to treat mental disorders that can be conducted in primary care. And so the question was, if training itself weren't a barrier to integrating these evidence-based interventions into TB programs, what is the likelihood that at a national level, these types of this integration of these interventions would take place. And this was probably the most exciting finding from the study, because we found that 2/3 said that it was extremely likely that if this were available, they would absolutely very, very strong probability of integrating these kinds of services at a national level. And only 15% suggested that it might not, probably wouldn't happen at that time, even if it were available. And our last question was what the top perceived barriers were to integrating TB and mental health services if they were not already. And the top reasons that were cited were lack of capacity. So again, speaking to the training issue, that mental health was not recognized as a problem. And again, this was highlighted in the beginning of the survey when asked spontaneously what the top barriers to TB treatment success were, mental health did not come up spontaneously, but there were not enough resources. And we've also spoken today about, in particular, James Sale spoke about global fund advocacy that we're involved in right now, trying to create these resources that could be available to support these types of activities. And social stigma was the last perceived barrier. There were a few limitations that's important to acknowledge in this study. First of all, we did not achieve full geographic representation. There were a couple reasons for this. One was the language barrier. We were limited to the languages spoken by our team, so English, Spanish, Portuguese, and French. And there were gaps in available contact information. We saw it through the union and through the WHO. It was not possible to reach out to all the national TB directors from high burden countries. And also you'll notice that there's an oversampling from sub-Saharan Africa, which has a lot to do with the fact that the first year that we began data collection, we recruited in person at the annual union conference, which was in South Africa that year. Although I don't know that overrepresentation from sub-Saharan Africa is necessarily a bad thing, given the burden on that continent. And finally, it's important to note that this was just based on perceptions and opinions of the program directors at that time. So the conclusions of our study were that, first of all, effective low-cost interventions exist. And there's a number of resources available through the WHO website. There's many studies that are currently ongoing that hopefully the results of which will be available in the next year or two of integrating these very specific evidence-based interventions into TB programs and looking at how it impacts TB-related outcomes, TB and mental health outcomes and others. And secondly, there is political will. This was, as I mentioned, the most exciting part about our study was that there are limited resources and limited recognition, and there's a number of barriers, but there is political will. And so if we were successful in harnessing the resources that are available, for example, through the Global Fund and other mechanisms, this could be a reality in the short term. And this is something that we could do. And the final conclusion, of course, is that patient-centered care is critical to ending the TB epidemic. And I'll stop there. Thank you.
Thank you, Annika. Very, very interesting and useful. And I'm sure that similar results of a trend of thoughts and considerations could be found elsewhere. They are very, very relevant. And now the challenge is how do we overcome some of that? Because if the political will is there and if the tools are there, what do we need apart from resources that may not be there to make things happen? So we get back to the previous conclusions as well, in a way. So I have the honor to continue with the next one. Thank you, Teresa. And so we are moving, thank you, Annika, very much. And we are moving then to Brazil, my neighboring country. So we are going to talk about or listen about the challenges and progress in mainstreaming mental health in TB programming in Brazil. And Fernanda Dockhorn, National TB Program Manager from Brazil. She's the manager of the TB Central Control Program in Brazil, and she will share the challenges and progress that Brazil is taking to deliver integrated service, TB and mental health services as well to the TB patients in Brazil, in the country. So the floor is all yours, Fernanda. Thank you.
Thank you. I'd like to thank you, the organizer, for this invitation to talk about the Brazil and this huge challenge that is work with TB and mental health. So I will start. The tuberculosis is a deprivation-related disease. This slide, I try to show some important aspects about the disease in this relationship about social and mental health. So when someone is deprived for the social life and social network, like family, friends, partners, jobs, income, all this led to social isolation, excess of worries, lack of perspective in the future contribute to the worsening life condition and health, including mental health. Lack of home, access to health care can affect directly this living and health condition worse. So you can't think about physical illness. You have to think about the mental health as well. In general, the illness is accompanied by some degree of mental health disorders. All these contribute to the decrease the quality of life for this person. This circle is a set circle of tuberculosis. I try to show what the majority of the patients are subject to every day. Beyond the stigma, discrimination, the reduce of physical, mental capacity can contribute negatively to the TB treatment, lending a lack of adherence, unfavorable clinical outcomes, less cure, high death, and high loss to follow-up. Here in National Tuberculosis Program in Brazil, the TB is a compulsory reporting disease. In this report, we have some information about health and mental health problem. We have some information about some vulnerable population like immigrants, homeless, migrants, about social determinant of tuberculosis like cash transfer benefit, and some information about alcohol use and abuse use, illicit drug, mental disorder, and tobacco. I will show some data about these topics. So when you see the mental disorders, alcohol use and illness in new TB cases in Brazil in 2019, the majority is have alcohol use, almost 20%. The illicit drug use is the second one, 15%, and mental disorder is just 2.5%. But we think this mental disorder is like when the person change a lot his life and can't do nothing alone. It's like a very, very huge problem. When you see the vulnerable population, some targets, homeless, immigrants, foreign people. The immigrants is our biggest problem in the moment, is almost 12%, followed by homeless, and we have some migrants. About specific of mental disorder, I try to show the schooling, age, and gender. The majority has less than 8 years schooling. The age is between 14 to 69, the majority, and they are male. It's not different for the alcohol use, but the proportion of alcohol use is bigger than the other one. And when you see the illicit drug use, we see the age is the different. They are very young. They start like 15 years until 39 years old. When you see the clinical outcomes, they have worse the outcome, of course. When the mental disorder, they have less cure, the high default and high death, similar to alcoholism and illicit drug use. The illicit drug use is a huge problem, like the death is almost 25% of the people. So finally, I'd like to show the lessons learned and opportunities. It's very difficult to work with the mental health in the public health system, but the National Tuberculosis Program is already capturing some data about the mental disorder and psychoactive substance use. In our guidelines, we already recommend the approach centering the patient, the pillar 1, and the two important objectives is individualized care to detect barriers and treatment success, and offers the comprehensive package of care, including psychosocial support. We have a problem because the psychological support facilities are limited. So we'll try to improve the network between these facilities with the health primary care. And now you are working with a work plan developing a work plan for the target population. We have many challenges ahead. We have to training the health professional, because the health professional here, the majority of the time, they know work with the illness, physical illness is very difficult to work with mental illness. They need a support. We cannot work separate from mental health, physical health, and social problems. Many times the person have all the problems. And improve the center, the approach centering the patient and his family, because we recommend, but sometimes they don't work very well. So we have to improve this recommendation in the health facilities. I think it's this. I finish. Thank you.
Thank you, Fernanda, very much. It shows, I think, concrete example of what can be done, right? And we know that Brazil has a very strong and long history of working on TB, but also on mental health services and mental health care. So clearly, it is possible to do things together, and we hopefully will learn more about that in the future and see how we can also expand this experience to other realities. So now is the turn of questions and answers, right? So I'm asking Monica Diaz to coordinate this session. Monica is the cross-cutting lead for special initiatives in the Global TB Department. So Monica, all yours.
Thank you so much, Deborah, and thanks to our wonderful participants. We crossed 100 and we're on that level. And thanks to, thanks for all the very interesting questions. I can see that our panelists have been answering some online, but it would be good to raise some of these questions nevertheless and answer them live as well. So to start with, perhaps let's go with David Bryden from Results. David, I'm going to read out your question because it also links to what others have asked, like Dr. Deepak. So this is really for all the panelists. As David emphasizes, the agenda is urgent, including for people with drug-resistant TB. Can you identify for us any countries that are providing mental health services for TB patients? How many countries are they included in Global Fund proposals? And is this issue reflected in any TB policy scorecards, which are used for accountability, for instance, in Africa? So I turn to our panelists. Our co-chairs are also welcome to answer. So perhaps, Ernesto, would you like to go first?
Yes, well, I think that it's very clear there are opportunities. And the example of Brazil shows that it's feasible. Data collected by the study presented by Annika confirmed that there is willingness from the leaders of the TB control programs to embark on collaboration with the mental health department. What is crucial is to take advantage of this low-hanging fruit. There is a very clear need, the evidence is out there, right, that this is a problem. That is a problem that can be tackled, and that is a problem with the potential of having fundamental impact on treatment outcomes, which is quite often the main indicator that donors and ministries of health are more worried about. If we want to really reduce the incidence of tuberculosis, we want to reduce the burden of tuberculosis, we need to ensure that people get cured, but also that they have good quality of life in the process. And what we have gathered from the speakers today is a collection of compelling evidence about feasibility, effectiveness on interventions to tackle the burden, right? But require the political will to put the money on the table to fill the barrier that the NTP managers themselves have provided in this survey that Annika has presented. I think a fundamental step forward in the right direction is the decision of Global Fund to support the countries that submit proposals to address part of the gaps in the capacity that is necessary at country level, and a strong collaboration with mental health departments in WHO, in Geneva, but also in the base level where the services are delivered, where the real life is happening. So I think that that would be my opening point.
Thanks so much, Ernesto. Teresa, would you like to add?
Yes, I would like to complement to what Ernesto told, and based on the results of the survey, we've seen that the awareness still in the TB programs is very low, and we should start with this awareness. We should work with our programs and our colleagues, because how we can advocate if there is no full understanding of the importance of this work. So that's why I think that both me and Deborah, we know that a lot of work should be done, but definitely there could not be dual opinion that should it be done or not. It's must, it's essential, and we should tackle mental health issues and problems in all TB patients.
And then just to complement, because I have written before the issue of information, we talk about the need to do some training, of course, but awareness, information about this, I think, is the first step, and it will then allow the entire process to move ahead. I think it's crucial, actually, and we have, it is easy, it is doable, we just need to plan and do it.
Absolutely.
And also probably based on my own experience, country of my origin was not presented in the survey, probably because of the linguistic barriers, but definitely there are studies from the former Soviet Union, from Russia, that patients provided with the psychosocial support are bringing much better results, treatment outcomes, and more sustainable. So this is very important.
Okay, excellent. So that's quite a comprehensive response. Let's take another question then. This is from Tila to all panelists. Are TB patients more likely to suffer from common mental disorders than people with other chronic conditions? If so, what is it about TB that increases the risk of mental health when compared to other conditions, particularly those that may be as stigmatized as TB? And this we've seen touched upon from the personal experience of Zulelva, and I think other presenters also touched upon this. So over to the panelists to respond. Zulelva, would you like to take a first shot at this? And then we could go to Annika.
Hi again. So I'm not sure what it is. I mean, I'm not sure if it's the disease itself, or if it's just the hardships encountered with treatment that cause all of this. Because for me, I definitely think it was the hardship of how hard treatment was, how many pills I had to take, how long I had to take them for. And if I didn't take them, it meant I was going to get a stronger form of TB. And that meant almost certain death, you know? So there was just so much pressure on me to do it, and to do it by myself, and to not complain, and to just receive, because I was receiving treatment from the government, you know, so I wasn't paying for it. So a part of me was just like, okay, maybe I'm not allowed to complain because this is the treatment that's been offered, and clearly this is the way that it's given under. I mean, and even though I wanted to complain, and I did complain about the lack of psychological support, but because it isn't part of the program of treatment, it wasn't given. So for me, I think it has, I'm not sure about, you know, the scientific things to do with the illness itself, but for me, it was definitely the treatment burden itself and how toxic it was that caused me to kind of just lose hope in even getting cured, you know? So that's my response to that.
Thank you, Zulelva. Annika, over to you, please.
Sure. I have a few responses to that question. First of all, when some of the surveys that have been done, it looks as though the prevalence of depression may be higher than other chronic illnesses. There's some caveats here because most of the studies are done not with diagnosis, but with screening tools. So there could be an overrepresentation, but certainly there's evidence that it's at least as burdensome in TB patients as other chronic illnesses. And there may be some factors that are associated with TB itself. The fact that, as Zulelva was mentioning, the side effects, in particular for drug-resistant TB, are very extreme. Also, it's an airborne infectious disease, which has its own elements of the social isolation and stigma related to that. You know, it is very specific to TB. And then there's also, there's hypothesized reasons why biologically there might be a reason why it's higher in TB patients, which is along the lines of inflammation. And I cited a paper in the comments where we examined all of the hypothesized mechanisms through which inflammation could be one of the factors that that makes depression, in particular, that paper is focused on depression, higher in people with TB. But really, these are questions that we have that we don't have complete answers yet.
Thanks a lot, Annika. Deborah?
Yeah, just to add a couple of other thoughts, and one was the issue of TB being a chronic or long-term condition. That itself brings also together the struggles to manage it and the challenges, and then depression comes along with that. And the other issue was isolation is known risk factor for depression, and we are also seeing it the current COVID-19 related situation as well. No? So the need for this isolation, social isolation, as it was mentioned before, and stigma was one of my notes. I think stigma is also very much related. I was then wondering if we share, we in terms of people with TB and people with mental health conditions, share some kind of common social determinants there, right? In terms of the association of these conditions with living in poverty conditions, for example, yes, and what is the impact that both have in common, maybe, that could contribute as well. I don't have the answer, just hypothetical issues. Thank you.
So definitely, and as I told at the very beginning, there are clear linkages and between the diseases, and also I would like to add to what my colleagues told, that it's already proved, and according to the evidence, some TB-specific drugs has adverse effects as depression. And it's clearly indicated, and we know it in advance, and we should, that's why, monitor very carefully. And also suicides are very frequent, accompanying, unfortunately, TB treatment. It's still long, as I told, very toxic drugs, and plus to other determinants and conditions, of course, it multiplicates negative impact on mental health. So that's why it's clear, it's proved, and we can't ignore it.
Thanks so much. So we'll take two more questions. So one question is now going into the nitty-gritty, and I see that, Aisha, you've responded to it online, but I think it's good for the audience. Excuse me. What screening questionnaires are recommended to assess mental health among TB patients to be administered by healthcare workers? Very concrete question from Dr. Deepak B. So Aisha, Malik, would you like to take it first? And then other panelists, if you'd like to respond.
Yeah, thank you. No, indeed, a very concrete question. I think two that I'll talk about, one is the PHQ, specifically PHQ-9. There's another version, PHQ-2 as well. And these have been used in low and middle income settings and are validated in those settings. For alcohol, I would mention audit C or CIST as well. And I think what's particularly important to think about when it comes to screening and measurement in these contexts is that the tools are validated and are normed in the cultural setting that it's used. And I think one of the issues we come across in the literature is that's not necessarily always the case with the measures. Thank you.
Thank you.
No. Okay.
Thank you, Aisha. That's very helpful. Would any other panelists like to respond?
Can I share the experience in Brazil? So about the screening, we have some research with this because the primary healthcare have many work to do, and the screening for psychological problems is huge. They are different. They look for different problems. So now we don't have one screening for all the country, but we have some research in some states try to simplify the work for the health professional in the primary healthcare. Because if you recommend a huge screening, they don't will work. We know that. So we try to simplify, like you have to think about this, think about that. Not just if the person have a very visible problem, like a alcohol abuse or illicit drug abuse. I think it's more difficult to see about the depression. The thing is not so visible. We have to look for, yeah. And I think the approach in the center of the patient is very important about that. The medicine in Brazil, they change a lot along the years. They try to different strategy. They have many specialist doctors, but we need one person to look for the patient, all the problems in the patient, not just one disease. So the center, the approach in patient the center is most important, I think. Thank you.
Thank you so much, Fernanda, for sharing your experience. That was really useful. And I can see in the comments that some people have shared experiences, for instance, from India. But yes, definitely more scope here for discussion. So let's go to the last question now. And here I'll ask each panelist to quickly give a response. This is from Blessy Kumar, who we know well from our WHO Civil Society Task Force, the Global Coalition of TB Activists. So she says, a lack of support for mental health issues are serious barriers in the TB journey. We have more than enough evidence on this. The big question is, how are we addressing this in practical terms? What can we do at country level? We really need action now. So we invite each panelist, and maybe Zalelva, you can start, a quick practical suggestion for change. So Zalelva, over to you, please.
I think, okay, what I'm going to say is, yeah, simply offering psychosocial support to all patients that are on TB treatment. When I say psychosocial, I mean social as well, so financial, and then psychological as well, screening to make sure that they're not depressed, and just continuing to follow them up that way throughout the whole of treatment, not just the focus on sort of the focus that directly observed treatment has, where we're just looking at them taking the treatment. We need to go beyond that and actually find out how they're doing on treatment, motivating them to continue treatment, giving them goals of why they want to complete treatment, because these were all things that people helped me to sort of establish for myself. But it would have been so much better if it was part of the actual system of when we're administering the drugs, we're also trying to find out how they're coping through the treatment. Yeah, thanks.
Thank you so much, Zalelva. That was excellent. Thank you for sharing. Ernesto, as the next in line, would you like to share one practical tip?
Thank you. No, it's very simple. question to make, but complex answer because the interventions are at a very different level within the health system. And that begins with the patients themselves and the healthcare providers to think always in the mental health challenges that people are facing while going through the TB journey. But also when we move up into the ladder of responsibilities, then it's going up to WHO to really be championing this collaboration at all levels and convincing the donors to step in and provide the support needed, which is not an awful lot of money. I mean, when you compare with the cost of new medicines for TB, the cost of the management of mental health conditions are peanuts. It's nothing, and the interventions are proven. So it's just a matter of materializing the political will. And another fundamental component in which the experience of Brazil, I think, is very useful and practical. The recording and reporting system has to start capturing this comorbidity, because otherwise it's impossible to make the case for the donors, but also very difficult to monitor the progress we are making in tackling the challenge. Thank you.
Thank you, Ernesto. Over to you, Aisha.
Thank you. I think I would give the point of how important it is to build capacity in the health staff that are working in TB centres at the moment. And that's capacity in identifying mental health, being able to distinguish some of the overlap in symptoms between mental health and TB, and being able to manage it and follow up with mental health. That's not just ongoing training, that's pre-service training as well, so that the future workforce in TB has the ability to articulate around mental health. Thank you.
Thanks a lot, Aisha. Over now to James Sale. James.
Thank you. So one big thing that everybody in this call can do is everybody can support World Mental Health Day and make TB visible within that and start talking about the issue. And there's three things that everybody can do. You can support hashtag Move for Mental Health, which is also going to be on the social media platform TikTok, where there'll be a dance for mental health, and we're hoping that really picks up speed to gain visibility on the issue of ill mental health. The second thing you can do is you can support the Speak Your Mind 24-hour virtual march for mental health, where 17 countries with groups of campaigners will be passing the baton on each hour to each other to campaign about mental health in their countries. And then on top of that, we have a number of thematic hours as well. And then the third thing you can do is you can tune in and support the WHO's big event on mental health on 10th. It's going to be a fantastic thing. So we can all of us immediately do something this weekend to support mental health and therefore support mental health and TB.
Very exciting campaign indeed. And yes, this week has been all about World Mental Health Day, and I'm sure Deborah will add more towards the end. I'll turn now to Anika. Would you like to go next?
Yes, sure. So first, I would echo everything that was already said. But in terms of the most practical response, I would say that routine screening is the most important thing that could happen. And I can share a very brief anecdote about this from my work in Brazil, where I was leading a pilot project to integrate depression treatment in primary care. And we were using the PHQ-9. And I introduced this tool. We trained everyone to use it. Within the TB program, they were going to identify people with depression and attempt to provide treatment to them with an evidence-based intervention recommended by WHO. And about a month in, they said, you know, we're still not finding anyone with depression. And I was like, that seems very unlikely given what we know about how frequent it is. Are you sure that, are you screening everyone with the instrument? They said, oh no, we're just, you know, they're screening people that appear depressed. I said, well, why don't you try routine screening? And as soon as they did that, they started finding all of these people that, you know, maybe looked okay, or, you know, put on a good face when they came in for treatment, but really were struggling, and even to, you know, with some suicidality in some cases. And they were so shocked, and they instituted immediately this as a standard protocol. So I would say from a practical perspective, identification of this, of mental disorders is probably the most important thing, because it's the most under-recognized but treatable condition that we can address to improve outcomes.
Very practical recommendation, Anika. Thank you. Fernanda, over to you, please.
Thank you. I think the most important is the build the linkage between the programs and the process of tuberculosis treatment and mental health psychological facilities here in Brazil, and work with stigma, because stigma is very, very important in tuberculosis and mental health as well. In Brazil, where many people have huge stigma about depression or mental disorder, they don't want to go to the psychiatrist and the doctor to treat this kind of disease. So I think when we integrate and maybe a protocol with a screening, training a health professional, how to identify the problem is important. And we are trying to work on with this. Thank you.
Thank you, Fernanda. Excellent suggestion. I now turn to our co-chairs in the room. So yeah, Deborah, please.
Thank you. When I was a student in college, I was doing my practice in a big psychiatric hospital, of 3,000 beds. And that's when I learned that TB existed, because every winter people will die, patients will die with severe TB, untreated, unseen. And after that, and I think this is still the case in many institutions around the world. Then after I learned that patients with TB will have also mental health conditions. I think that's with the evidence of what we heard today and what we know, we absolutely know enough about what needs to be done. So now the challenge is, how do we do it? And I think also we have learned about what ways we could follow and how to get there. I just want to say thank you to Teresa and the department and the colleagues that presented, because I think this is a great opportunity for us to make sure that through yet another network, in this case TB networks, together we will convince those managers that were still to be convinced about what needs to be done. It's not so complicated, it's not so difficult, it's not so expensive. So why are we not there? Well, we should get there soon. So I just want to say thank you, and we are committed to continue this collaboration. We are planning to develop a module that will seek at a better integration of depression, in particular to some so-called physical conditions like TB, and we will count on all of you for a better development and the implementation. And then just to repeat a couple of things that James said, we are having the big event for mental health on Saturday, but before that, the hashtag Move for Mental Health is already active. TikTok, I don't know what it is, but I understand it's important. TikTok, Facebook, Twitter, LinkedIn, we are everywhere. On social media, we have something there. I tried to join some, I couldn't, but younger people or more updated people, I'm sure everybody will do that. So please join us there. Join the big 24 hours event that United for Global Mental Health is running. And on Saturday at 4 p.m. Geneva time, let's join us and disseminate this information for everybody to join a few hours of mental health in a way a bit different than what we usually do, presenting how to see the problem, how to solve it, and listening to those who have their own experience, as we heard here, to talk about that. Thank you very much.
Thank you.
So, thank you very much, dear colleagues. Participants were running out of time, but I see that people are still with us. They're giving a prioritization for this very important topic, and it's very inspiring. And I would like once again to thank our colleagues for this wonderful collaboration. And it's time indeed. You know, this our slogan of the World TB Day, it's time to end TB, and not only end TB, but look at the people suffering at their needs. I'm always keeping in my mind old principle with which I was educated. You should treat patient, not disease. So, and patients have multiple diseases, and we cannot be satisfied if we're just selecting one and tackling and treating, and patient is still continuing suffering. So that's why our collaboration will be resulted in the better, definitely more sustainable results for our patients. So that's why I would like to address my request to our TB program managers. Of course, you are facing numerous challenges, but you are the core people and of course, jointly with the civil society in all this fight. Of course, we are from WHO, from our side, we'll try to do our best. We will provide the guidance, we will lead. But if this not come out from you, it will not be implemented. And you should be the strong advocates and include in your national TB programs these elements, very simple but very impactful elements, as a screening of all TB patients during the treatment for some adverse events and side effects. Another thing, definitely, it's important, and we should start with this, some essential training for all the staff engaged, and to be sure that the necessary knowledge is present. Another thing, identify the groups just before even you start the treatment who will definitely face the problem. And you know, these are people who were already treated on the retreatment of the TB, and they will have to go to again to this long journey. They will definitely face the challenges. Patients with a multi-drug resistant TB, patients with a history of the mental health issues before, and we should clearly identify it in the beginning of the treatment. So that's why we know very well about adverse effects of some TB-specific drugs, and this is the only one way. And I hope, I believe that through collaboration and partnership is the best way to help to our patients. Let's continue. And I think that this webinar is the first example, but we should definitely continue with this. So, mental health for all. Yes. And TB. Okay, thank you.
Thank you.
Thank you, everyone.
Thank you.